Assalamu alaikum. Today I'm going to read a clinical case number 30, that is, a child with a troublesome wheeze. This case is about a 6-year-old boy who has been experiencing recurrent cough and wheeze for the past 2 years. His symptoms are present most days and get worse when he has colds. His GP initially prescribed a salbutamol inhaler given through a large volume spacer, which provide symptom relief. However, he needs to use it almost every day, but he frequently coughs at night. Due to the persistence of his symptoms, he was started on beclomethasone dipropionate 200 nanogram twice a day, also through a spacer. GP believes his inhaler technique is correct, that his family is following the treatment plan. However, both parents smoke, though they claim they only do so outside the house. On examination, the boy's height and weight are on the 75th centile. He does not have cyanosis or clubbing, but he has a Harrison's sulcus and a mildly increased thoracic anterior-posterior diameter, which suggests that his breathing has been chronically affected, likely due to persistent respiratory effort. Auscultation reveals occasional scattered wheezes. His spirometry results show that his forced expiratory volume in 1 second is 83% of the predicted value, while his forced vital capacity is 96%. This suggests airway obstruction as the forced expiratory volume 1 is reduced more than the forced vital capacity. Additionally, his fractional exhaled nitric oxide level is elevated at 56 parts per billion, which indicates airway inflammation commonly associated with asthma. At this point, the diagnosis of asthma is quite clear. The child exhibits a pattern of multi-trigger wheeze, meaning that his symptoms are not solely caused by viral infections, but also by other environmental factors. This distinguishes it from viral episodic wheeze, which is more common in younger children. Asthma is a chronic inflammatory condition of the airways characterized by reversible obstruction. It manifests with symptoms such as breathlessness, wheezing, coughing, and chest tightness. These symptoms tend to be variable, intermittent, and often worsen at night. Asthma attacks can be triggered by various factors, including exercise, allergens, infections, and environmental pollutants. Asthma severity is classified into 3 categories: mild moderate, severe, and life-threatening. In mild moderate asthma, the patient presents with normal vital signs, a mild wheeze, and the ability to speak in complete sentences, or children with continuous feeding. There are no clinical signs of severe asthma, and oxygen saturation remains above 92% in room temperature. In children aged 5 years and older, peak expiratory flow rate is greater than 50% of their predicted value. In severe asthma, the patient exhibits signs of significant respiratory distress, including being too breathless to talk, feed, or eat. Respiratory rate increases based on age, greater than 40 breaths per minute in children under 5 years, greater than 30 in children aged 5 to 12 years, and greater than 25 breaths per minute in those aged 12 to 18 years. Similarly, heart rate is elevated, greater than 140 beats per minute in children under 5 years, greater than 25 beats per minute in those aged 5 to 12 years, and greater than 110 beats per minute in teenagers. Other signs include the use of accessory muscle for breathing, subcostal and intercostal recession, flaring of nostrils, oxygen saturation below 92%, and peak expiratory flow rate below 50% in children aged 5 years and older. Now the life-threatening asthma. This is a critical condition where patient may appear exhausted, irritable, or have altered consciousness. They may have cyanosis, decreased air entry into the lung, and poor respiratory effort. Oxygen saturation falls below 92%, and peak expiratory flow rate is 30% or less of the predicted value. A concerning aspect is that some children may not appear highly distressed despite having life-threatening asthma. So the presence of any of these warning signs should raise immediate concern. Before diagnosing asthma, it is important to consider other conditions that can cause similar symptoms. One possibility is an inhaled foreign body, where a small object such as a piece of food or toy gets stuck in the airway, causing wheezing and difficulty breathing. This is especially common in young children who tend to put things in their mouth. Another condition that can be mistaken for asthma is pneumonia, which is lung infection. Pneumonia causes cough, fever, difficulty breathing, and sometimes chest pain, unlike asthma. Pneumonia usually comes with signs of infection such as high fever and mucus production. A collapsed lung, also known as pneumothorax, can also cause sudden breathing difficulty. This happens when air leaks into the space between the lung to expand properly. It often causes sharp chest pain and breathlessness, and it requires urgent medical attention. Aspiration, which occurs when food or liquid accidentally enters the airway instead of the esophagus, can also mimic asthma. This can happen in children who have difficulty swallowing or in those who have neurological conditions. Repeated aspiration can lead to lung inflammation and chronic coughing. Cystic fibrosis is another condition that can present with asthma-like symptoms. It is a genetic disorder that causes thick, sticky mucus to build up in the lungs, leading to chronic cough, recurrent lung infection, and breathing difficulties. Unlike asthma, cystic fibrosis is usually diagnosed in early childhood and often comes with digestive problems as well. Another possible cause of wheezing and breathing issues is tracheobronchomalacia, which is a condition where the walls of the airway are weak and collapse easily. This can make breathing noisy and difficult, especially when the child is crying or coughing. Gastroesophageal reflux disease is another condition that can be mistaken for asthma. In gastroesophageal reflux, stomach acid flows back into the throat and airway, causing irritation, chronic cough, and sometimes wheezing. This is more common in infants and children who frequently spit up or have heartburn. Lastly, hyperventilation, which means breathing too fast or too deeply, can sometimes be confused with an asthma attack. This can happen due to anxiety, stress, or panic attacks leading to breathlessness and chest tightness. Unlike asthma, hyperventilation is not caused by airways narrowing but by an imbalance of oxygen and carbon dioxide in the blood. Since these conditions can mimic asthma, doctors need to carefully evaluate the symptoms, medical history, and test results before making a final diagnosis. A comprehensive assessment involves recording respiratory rate, breathing effort, signs of recession, heart rate, air entry into the lungs, and oxygen saturation. Children aged 5 years and older, peak expiratory flow rate measurement provides additional information about airflow obstruction. In severe and life-threatening cases where symptoms do not improve with initial treatment, a chest X-ray may be preferred. However, routine blood tests and arterial blood gases are not required in typical asthma cases. Asthma management depends on severity of symptoms and follows a structured approach. If a child is experiencing difficulty in breathing due to asthma, oxygen is given if needed, and treatment follows a specific algorithm for handling acute wheezing episodes. For mild to moderate asthma, the first line treatment is salbutamol, which is administered through a nebulizer with oxygen at a flow rate of 6 to 8 liters per minute. The dosage depends on the child's age. Children under 5 years receive 2.5 mg, those between 5 and 12 years receive 2.5 to 5 mg, and children older than 12 years receive 5 mg. In case where additional relief is required, apratropium bromide can be added to the nebulization. This is given at a dose of 250 micrograms for children under 12 years and 500 micrograms for those over 12 years. Since asthma involves inflammation of the airways, oral prednisolone is prescribed to help reduce swelling and inflammation. The maximum dose depends on the child's age. Children under 2 years can have up to 10 mg once daily. Those aged 2 to 5 years can help up to 20 mg once daily. And children over 5 years can take up to 30 mg once daily. After initiating treatment, the child's response is monitored every 15 to 30 minutes to check for improvement. If asthma attack is more severe and the child does not show significant improvement with initial treatment, a senior doctor needs to assess the situation. In such cases, IV salbutamol is given as a bolus dose over 5 minutes. The dose is determined by the age, with children under 2 years receiving 5 micrograms per kilogram and children over 2 years receiving 15 micrograms per kilogram. If there is still no response after 15 minutes, IV magnesium sulfate is administered at a dose of 40 mg per kilogram over 20 minutes with a maximum limit of 2 grams. If symptoms persist despite these interventions, an IV infusion of salbutamol is started and adjusted based on the child's response to treatment. In life-threatening cases where the child continues to deteriorate despite aggressive treatment, immediate admission to the pediatric intensive care unit is required. Oxygen therapy is continued with continuous nebulized salbutamol and intravenous corticosteroids such as hydrocortisone. If the child shows signs of shock, intravenous fluid resuscitation is performed using sodium chloride 0.9% at a dose of 20 ml per kilogram. If there is still no improvement, advanced interventions such as mechanical ventilation may be necessary to support breathing. Throughout treatment, continuous monitoring is crucial. When using salbutamol, heart rate and respiratory rate are checked every 10 minutes, while oxygen saturation and cardiac activity are continuously monitored. If magnesium sulfate is used, vital signs must be checked even more frequently every 5 minutes, along with continuous cardiac and respiratory monitoring. Before a child can be safely discharged, several criteria must be met. The child's oxygen saturation should be at least 94% in room air, and their respiratory and heart rate should be within normal limits for their age. Additionally, their peak expiratory flow rate should be at least 75% of their predicted value, and they should be stable on 4-hourly inhaled treatment. Before leaving the hospital, parents must be educated on how to properly use inhalers and spacers. They should also be provided with a written personal asthma action plan that outlines how to manage symptoms and what to do in case of worsening asthma. A specific discharge plan, including a sleep down regime for salbutamol, should be given so that parents know how to gradually reduce its use. Additionally, parents need to be informed about common asthma triggers and signs of deterioration to watch for at home. A follow-up appointment with a general practitioner should be scheduled within 2 days of discharge. If there are concerns about exposure to cigarette smoke, families should also be referred to smoking cessation services. For long-term asthma control, inhaled corticosteroids should be considered for children who have frequent episodes, require bronchodilators more than 3 days per week, or experience symptoms at night or during exercise. If allergic rhinitis is contributing to asthma symptoms, additional treatments such as oral antihistamines or nasal steroids may be needed. Asthma is a serious condition, can be effectively managed with timely treatment and proper monitoring. Recognizing the severity of symptoms and initially the appropriate treatment early can significantly improve outcomes. In the long term, avoiding triggers and ensuring regular follow ups are essential for maintaining good asthma control and preventing severe exacerbations. Here is the first question asked in this case, that is, what is the most appropriate management? Select one answer only. First option is add inhaled salmeterol 50 nanogram twice a day. Salmeterol is a long-acting beta agonist and is not recommended as the first step for therapy escalation. Long-acting beta agonist should only be added if moderate dose of inhaled corticosteroid alone does not control symptoms. Since there is no clear evidence that inhaled corticosteroid alone has been optimized yet, adding a long-acting agonist is premature. Next option is add oral montelukast 5 mg daily. Montelukast is useful for asthma related to allergies and exercise-induced symptoms. However, it is less effective than inhaled corticosteroid in persistent asthma. It can be used as an add-on but not as a direct alternative to increasing inhaled corticosteroid. Option is change the preventer to inhaled fluticasone propionate 125 nanogram twice a day. So it's wrong because as fluticasone has similar potency to budesonide, but there is no added benefit in switching to this from beclomethasone unless there is an issue with inhale's technique or adherence. Next option is increase clinal modulate to 400 nanogram twice a day. It is incorrect because this is a high dose, and before jumping to a very high inhaled corticosteroid dose, it's better to optimize the current dose and consider formulation change first. So the answer is change the preventer to inhaled budesonide 200 nanogram twice a day via dry powder inhaler. Budesonide is an inhaled corticosteroid with stronger potency than beclomethasone, making it good choice when stepping up treatment. It is delivered via dry powder inhaler, which may improve dry delivery if the child struggles with metered dose inhalers. According to guidelines, stepping up inhaled corticosteroids is the first line choice for persistent asthma before adding LABAs or leukotriene receptor antagonist. Here is the next question. What is the most likely reason for apparent failure of the therapy? Select one answer only. Let's roll out one by one. First option is he has inhaled a foreign body. Foreign body aspiration typically causes a sudden onset of symptoms such as persistent wheezing, cough, or stridor. Unlike poorly controlled asthma, foreign body aspiration does not cause variable symptoms that improve and worsen over time. Next option is he has steroid resistant asthma. It is wrong because steroid resistant asthma is rare in children and is diagnosed only after ruling out poor adherence and incorrect inhaler technique. Most children with asthma respond to corticosteroids at least partially. A complete lack of response strongly suggests non-adherence rather than true steroid resistance. Next option is his inhaler technique is poor at home. It is possible but less likely. Poor inhaler technique can reduce medication delivery and effectiveness. However, if fractional exhaled nitric oxide and lung function remain completely unchanged, it suggests the inhaler is not being used at all, rather than just being used incorrectly. While checking inhaler technique is important, non-adherence is still the more probable explanation. Next option is his parents are smoker. It is also incorrect. Parental smoking can worsen asthma and contribute to poor symptom control by increasing airway inflammation. However, second-hand smoke does not cause a complete failure of inhaled corticosteroids to work. If the child was taking the inhaler as prescribed, some reduction in fractional exhaled nitric oxide would still be expected, even if smoking was a contributing factor. So the answer is he is not taking his preventer inhaler regularly. The most common cause of poor asthma control in children is poor adherence to preventer inhalers. Many children only use inhalers when symptomatic rather than daily as prescribed. This leads to chronic airway inflammation, which persists despite treatment. Many children do not take their inhalers regularly due to forgetfulness, fear of side effects, or misunderstanding of the need for daily use. Fractional exhaled nitric oxide is a marker of airway inflammation. If the child was taking the preventer inhaler as prescribed, fractional exhaled nitric oxide levels should decrease. Unchanged fractional exhaled nitric oxide suggests chronic inflammation, meaning the medication is not reaching the lungs, likely due to non-adherence. If the child was taking the medication correctly, some improvement in symptoms or lung function would be expected. The complete lack of response suggests the medication is not being used consistently. This case is a structured approach to asthma management in children, emphasizing early recognition, timely interventions, and a stepwise escalation of therapy. It ensures proper discharge planning with long-term asthma control strategies to reduce future exacerbations. This is all about from this case. If you have any question, comment below, like, subscribe, and share.